Today we'll be talking to you about the project we were working on this weekend called CarePath-ASSIST, and our team consists of Sandy, who's an NHS anesthesiologist, Stanley, who's a PhD student at Ulster, and myself, Angela, who's a medical student at Queen's. So first, what is the problem that we tried to tackle this weekend? The problem that we tackled was the fact that healthcare professionals are not able to make timely decisions about surgeries. And this is because data that would reveal patient complexities and appropriate next steps are buried deep within complex information systems. So this means healthcare professionals have to go digging for this information, and it's not readily accessible. So, what is our proposed solution? We decided that we would develop a structured summary that clearly visualizes complexities in patient health, and this is to streamline decisions on surgeries. Decisions such as the best approach, best place to conduct the surgery, what's the best team to assign for the case, and most importantly, it's also to help make decisions regarding if surgery is actually the best choice for each individual patient. So, the challenge for this problem was that creating a structured summary is actually just an information processing task. And doing this manually can be expensive, inefficient, inconsistent, and inequitable. So that's why we have decided to pursue this project.
Yeah, and maybe I'll take that. As a consultant anaesthetist, I have a lot of experience with pre-op assessment, and the system's caving in on itself. So we just looked at the main information steps, and Stanley and I, who is a PhD student, I'm actually supervising, we're breaking this down into the key steps and the key variables that you need to extract to structure decisions around day case, short stay, whatever. And fundamentally what you see there are the key outcomes, and we're providing a narrative and a summary narrative so that the pre-assessment nurses can pick that up. Next slide. So what we actually have created a synthetic data set of some outcomes that I've done already, and we're now starting to put that through the pipeline to look at how that would. So we've got some data flowing, we've got some outputs coming, but fundamentally, if we go to the next slide, this is about implementing the get it right first time pre-operative assessment screening process at scale, cost effectively, rapidly. We have tens of thousands of patients that need this done. We can't pay a consultant anaesthetist to sit in waiting list initiative clinics because it's too expensive, and we can't do it quickly enough. So fundamentally, this is about, we have a team. I'm working with the department and the data science colleagues, and it's all coming together. So realistically, next steps is about formalizing this, getting the support, and just executing a data analytics at scale for access to surgery. Thank you.
I'm going to go and let Dawn have the first question because she didn't get time for another one, so sorry, judges.
Hi, I just want to ask how exactly this would integrate currently with the EPIC system, because on EPIC you can actually add a diagnosis at the bottom of the page, which comes there as part of your drop-down menu, and you also have access to things, for example, like allergies, blood groups, and BMI, which are like key factors for you guys as anaesthetists. So if you knew that somebody was pregnant and had a history of polycystic ovary syndrome and had a history of anemia in this pregnancy and didn't have English as first language, and was rhesus negative, how does what you're developing actually supersede that or add to that?
Is that it's not
It
is
is.
it? Hello? No, oh, sorry. Technophile. Right. So what you've introduced there is an obstetric patient having a non-specific surgery, but this is about synthesizing the information and creating essentially an output summary. We've piloted this already in EPIC. We've done it manually. Okay, so we have a structured summary that includes all the decision critical variables around making. It's about patient risk, control of long-term health, and performance status. Yes, you'll have some nuance in the obstetric population, but from a general surgical, urology, ENT, catch-up, orthopedic point of view, it boils down to risk, control, and performance status. And if you can provide that summary back into EPIC, so you get the data in from multiple systems, provide that summary back in, you have a very, very effective closed-loop system that actually standardizes the information processing in a way that we're currently not achieving. And if we were making access to health decisions with that level of inconsistency, the way we made financial decisions, the ICO would be all over us. So it's a closed loop with a very simple summary.
Hi. Sandy and colleagues, very good presentation. Absolutely major problem, improving productivity in elective surgery, and getting serious quantitative analysis into our system is very, very welcome. I just wondered, was there a limiting factor? A lot of this assumes all of that data is there. You know, is it a limiting factor, the bit that happens before all of that?
Most of it actually is. And I chat to people and they're like, oh, well wait, Epic's going to do this, UK Foundation System's going to do the health questionnaire. We actually have the information sitting in CCG, Enhanced Prescribing Database, what's lying around in PAS. We can actually augment it with a wee bit of health. Northern Trust does health questionnaires. So we have the majority of the data to do this for the majority of patients. And we shouldn't be waiting.
15 seconds.
Excellent presentation. Information changing behaviour is your huge assumption. Acceptability of this to your surgical colleagues?
They love it. As soon as their big problem is actually trying to create waiting lists, and they're getting into Epic and they're trying to screen patients, and this is essentially a risk tolerance matching exercise. Will that person do that patient in that theatre on that site for this, you know, and that's really difficult to standardise. That's what this does.
Well done. Well done.